Okay, so I guess we'll get started. Good morning, everyone, and welcome to Making the Connection, Conversations Around Integrated Care webinar. I'm Yvette Kelly with the Managed Care Technical Assistance Center, and today I'm joined by a few of my colleagues, Forrest Meg Beyer, and Tara Reddy, as well as our partners from the Office of Mental Health, the Office of Addiction Services and Supports, Department of Health and Mental Hygiene, and the Center for Practice Innovations. Uh, Next slide, please. Thank you. So here's a quick look of what we're going to be covering in today's webinar. We will start with a brief introduction to the purpose and format of this series before moving forward with today's presentation. After the presentation, we will open it up for Q&A. So please feel free to chat in any questions or comments you may have along the way, utilizing the chat box. And then lastly, we will be asking you to complete a brief feedback survey at the end. We do look forward to any feedback that will help us improve. So if you can take a few minutes at the end to complete, we would greatly appreciate it. Next slide. So before we get started, just wanted to offer up some information about the series that we are running today. So today's webinar is the second in a series of 6 webinars intended to initially support New York City Article 31 clinics, but recently opened up to Article 31 clinics statewide, to really assist providers in exploring different strategies and approaches to promote integrated behavioral health care. As we know, these approaches improves the outcomes for this group and reduces cost of care. So while this is a 6-part series, providers are free to join whichever webinar they feel will best meet their needs. I do believe that once you register for the webinar, you're actually registered for all of them, but please don't feel obligated to attend if you don't feel that they would be helpful. But we did want you to just be able to have that on your calendar. So each interactive session will address and highlight a key topic area for discussion, as well as preview a case example from the field. So if you're interested in submitting a case for future presentations, and actually we highly encourage anyone who's interested to utilize the survey link that's provided. And again, you will get these slides to submit your cases. As I mentioned, the slides from today's presentation will be made available. And for those of you who were unable to join us previously because you did not get the invite, but now you're here with us, we will be sending out the slides to the first offering as well, just so if you want to be able to refer back to that, you will be able to do so. And with that, I'm going to pass it over to our colleagues from the Center of Practice Innovations, who will be leading us through today's presentation. Again, thank you all for joining.
Thank you, Yvette. Hi, I'm you can see I have 2 names. I'm Forrest Rusty Foster. No one's ever called me Forrest, just a couple people in my whole life. So if you want to call me by name, it's Rusty. And I'm a senior implementation specialist at the Center for Practice Innovations, the focus on integrated treatment. And we've been working, I've been at CPI for 10 years, and we've been working with clinics and PROS programs and residential programs throughout the state to help people implement integrated treatment. And I'm here with Nancy Covell, who maybe will say a few words about herself.
Oh, sorry, I had to find the unmute because I'm sharing my screen. Hi, everybody. I work with Rusty on the Focus on Integrated Treatment initiative at the Center for Practice Innovations, and we are glad to be here with you today.
Okay, so you see the title is Working with People Who Have Mental Health Conditions and Use Alcohol, Drugs, or Tobacco. So, and so we really want to take an integrated approach. And the format that we're going to use is we have a case. This is a not a real case. We kind of wrote this ourselves. Mostly Nancy wrote it. And we're going to read the case. I'll read the case. And so think about this person. And it should sound like somebody that comes to your clinic that you probably worked with. And so we're going to read the case, then we're going to go through some slides on integrated treatment and, components, core components of integrated treatment. We're going to go through those slides. Then we're going to go back to the case, and we're going to have the case so that you could keep looking at it. And we're going to use a format that was developed. I was part of the National Implementation Study for evidence-based practices, and we developed a format that people who are bringing in a case could also participate in coming up with solutions to some of the problems that the case poses. So we do a brainstorm, and we do that because I'm not a person that likes to just talk to people and then everybody's out there in cyberland. We don't know what they're doing, and I've been in webinars where you get bored and you because you don't want to keep listening to the same thing or the same person. So we want to get people involved. We're going to be very interactive. So that's the way we're going to do it. And at the end, we'll then also open it up for question and answers. So I'm going to read this case, and it's Femi, and Femi was referred back to the clinic upon discharge following a 2-week inpatient stay after staff at the residential program noticed she began using K2, which is K2 is a substance that lots of clinics are worried about. Okay, so she stopped taking her psychiatric medications and increasingly spoke about people who are following her and trying to steal her ideas. She was discharged back to the residential program with the prescription for risperidone. Prior to this recent hospitalization, Femi sporadically attended appointments at the clinic, and clinic staff had been unable to reach Femi for about a month before her most recent hospitalization. According to the records, Femi is 45 and identifies as a Black woman. She was born in the Bronx to a single mother and has one other sibling, an older sister, who still resides in New York City. Femi's mother passed away about 10 years ago, and her father reportedly lives in Jamaica. While she maintains a good relationship with her sister, it is unclear whether she is in contact with her father. According to her discharge records, Femi has had a series of hospitalizations beginning in 2000. At the time of her first hospitalization, her sister reported that she was having angry outbursts and saying strange things like famous rap artists were stealing her thoughts and getting rich off her lyrics. Subsequent hospitalizations usually followed a period of substance use and unusual experiences and outbursts. Femi has acknowledged using alcohol, marijuana, crack cocaine, and K2 during various stays. She states that she has stopped drinking and smoking marijuana, but is not interested in addressing her K2 or cocaine use at this time. However, she tells staff she is constantly taking her psychiatric medication, and residential staff have confirmed this is the case. While Femi was willing to talk with counselors over the phone for an intake and a few follow-up meetings, she sporadically attends her in-person appointments. In discussions with clinic staff, Femi has shared that she would like to find independent housing and to get back to work as a certified nurse assistant in a retirement community. Clinic staff would like to engage Femi into participating in her inpatient appointments more consistently. At the same time, they are worried about how to keep her safe as she continues to use substances. So we're not gonna reread it, but we will revisit it at the end when we do the brainstorm. Okay, so yeah, we can go to the first slide. So we're going to start with engagement because, and we're going to talk about why would we do that? Why are we starting with engagement? Why is that important? Well, by the research, by the literature, a poor engagement predicts exacerbation of symptoms, rehospitalization, and not fully realizing the potential benefits of treatment. And the reason is people with co-occurring mental health and substance use disorders really struggle with engagement in office treatment or treatment. And so they don't get engaged, they stop their medication, they start their medication, they come in, they don't come in. And so they don't get the true benefit of what you're offering them. If they do, though, if we do engage them and they do get engaged in treatment and they stay in treatment, in other words, they come in once and then they come in again a few times at least, they have improved outcomes. So that's why we want to figure out how to engage people. And one of the core principles, core components of integrated treatment is the concept of assertive engagement. So we want to talk a bit about more what helps engage people. Okay, next slide. Thank you. And so we're going to start with clients, and Luxted did a survey of clients, and one of the questions was, what helped engage you in being involved in treatment? What worked? And this is what they said: that relationship is key. And that means we project warm respect. We have warm respect, friendliness, interest, patience, and sincerity. And unfortunately, a lot of people who come in for treatment or for services haven't gotten this. They've been, they have been dismissed, or they've been sent to other places for treatment, or they're looked at as worrisome because they're using drugs and alcohol. So this is the key piece in engaging people. And I'm not saying you don't know this and you don't do this, but this we just need to talk through this and see how this could apply to FEMI. Providers showed acceptance and support. Acceptance for it's that radical acceptance or unconditional positive regard, and support. We're here to support you. And they get individual care. It's not no cookie cutter care. Whatever care they get is designed for their needs and their interests. And they also felt that one of the things that keeps them engaged is that the focus of the services, the care, the treatment is on meaningful life goals. And I hate to say this, but it's not like a meaningful life goal is not you need to come in to treatment or you need to go to group. It's, really working on what they're interested in. And that's the last bullet, that the goals that that you're going to focus on, that the care focuses on, are identified by the individual. It's their goals. Okay, so that's what the clients say. Next slide. So now we want to talk a little bit about recovery-oriented care. And recovery-oriented care is like a foundational stone for integrated treatment. And maybe it's for all treatment, really. And so here's a definition that came from Tandora and Davidson. It looks a little old, but it's still very topical. And I believe it's something that SAMHSA adopted. So a recovery-oriented care, I'm just going to read this one. A recovery-oriented care system, a recovery-oriented system of care identifies and builds upon each individual's assets, strengths, and areas of health and competence. So it's strength-based. It's a strength-based approach. It's not looking at what the person can't do, what their problems are. It's looking at what they have going for them, what their strengths are, what they're competent are, and it's to support the individual in achieving a sense of mastery over their mental health problem and or addiction problems while regaining his or her life and a meaningful, constructive sense of membership in the broader community. So this paragraph, when we go back to Femi, it's like, how do we use this orientation to help Femi in what she's trying to achieve, and what her strengths and assets are. Okay, so here's some principles. The individual communicates, and when we go through this, we have the idea of what clients say works in engagement. There's the principles of recovery-oriented care. Then we're going to go to some stage-wise work. We'll just mention that quickly: motivational interviewing and harm reduction. And these are all overlapping. These all work together in an integrated fashion when we work with people with co-occurring problems. So individual communicates what is important for the treatment focus. It's a collaborative process. We try to level we can't completely level it, but level the power structure in treatment so that there's a sense that you're working together and that you're not the one who's the expert telling people what to do. Okay, so it's a collaborative process. The goals are based on the individual's unique interests, preferences, and strengths. We talked about that a little bit. Treatment is matched the unique needs of the individual. It's individualized care, and it communicates. We have to communicate an attitude of acceptance. And when we get into motivational interviewing, and I'm sure everybody's been trained in motivational interviewing, I don't want to repeat a lot of stuff you already know, but in the spirit of motivational interviewing, acceptance is one of the core elements in the spirit. We need to reduce stigma and shame. There's a lot of stigma and shame with mental health. There's a lot of work nationally now and through the media and through sports, actually, where people who have mental health problems are coming out and say, I have a mental health problem. And when they do that, when that happens, stigma is lessened. But stigma around substance use is really still very high. So some sports figure who says, I have, I'm having anxiety, versus a sports person that says, I've been using cocaine, there's a different response to that person. So we need to lower stigma and shame, especially around substance use. And we need to normalize co-occurring mental health and substance use problems. And that, one of the leaders in integrated treatment, Ken Minkoff, he came up with the phrase welcoming. You have to welcome people that co-occurring disorders is the expectation, not the exception. So we have, and in clinics, sometimes in clinics that I've worked with, people aren't sure they could work with people with co-occurring disorders. But in fact, when you look at who they work with, a lot of the people they're working with already have co-occurring mental health and substance use problems. Okay, so now we just want to talk about the stages of change and how that fits into recovery-oriented care and how it fits into the motivational interviewing. And the stages are written here. I'm sure you all know what the stages are. I'm beginning to have some concern about the concept of pre-contemplation. People call people pre-contemplators, and there's something pejorative about that and negative. And it's it reminds me a little bit when people were given diagnosis of borderline. It's this, all of a sudden you start thinking, oh my God, a pre-contemplator. So, but all that means is the person's not ready to change. Okay, that's all it means. So there's these 5 stages people go through in changing behaviors. Stages are behavior specific. A person's not in a stage. The person's not a contemplator. It's a behavior. So they might be in contemplation about their alcohol use, but not their cocaine use. So they're stage specific. Treatment is always provided that's matched to the stage. So if somebody is in contemplation, or somebody is not ready to make a change and is not interested in it, it doesn't make sense to refer them to a group that is action-oriented around drugs and alcohol, because they're not going to go or they're going to drop out. So we have to make sure we match our treatment to the stage, and we have to identify what stage, people use more, Femi uses multiple substances. What stage is she in for those 4 substances? And addressing motivation and tailoring treatment to stage is associated with engagement, retention, and more positive outcomes. So understanding where a person's at in the change process is very important. If we don't do that, we get a mismatch. So we try to normalize the ambivalence. I'll use myself as an example. Exercising is a big thing for me, okay? Doesn't mean I actually exercise, it just means it seems important to me. But I can be very ambivalent about it. And it used to be, I belonged to a gym, and I would say, I'd say in the morning, I'd say, I want to go to the gym. I'm going to go after work. And after work, I feel too tired. I'll go tomorrow. Okay. So ambivalence is important in the change process. In fact, without ambivalence, there's going to be no change, because in ambivalence, there's pros and cons about changing. Okay. So ambivalence is normal, and we want to normalize it for people. But we also want individuals to change. We're worried about people. The clinic is worried about Femi and her substance use, right? They want her, they want her to, it would be great if she stopped, okay? That's what they would like, okay? They would want that. But people are not ready necessarily to make a change. Even when they enroll in services, they might not want to make a change, okay? To me, because they're coming to see you doesn't mean they're ready to make a change. And if we, if we are pushing for change and they're not ready for change, people won't feel understood. They feel like you don't really understand where they're at. You're going to feel frustrated. And whenever you feel frustrated with somebody you work with, it really is a sign that you're kind of in the wrong stage, right? You're in a different stage. Let's put it that way than they're in. Okay. And when people don't feel understood, and you're feeling frustrated, and they don't feel that the treatment is really where they're at, that's when they disengage. Okay. And so we need to make sure that we stay where that person's at, and I know that, what's that? I can't remember the phrase, but be where the person's at kind of statement. But that's why, because and especially for people who have co-occurring disorders, because they struggle with not using their substance. And it's hard for them to imagine. And we have to think, not that it's bad, it's not a moral issue, it's not bad behavior. We don't need to feel that we have to get them to change. We have to understand why it's so hard for them. What is it about the substance that they keep using and they have all these negative consequences? So mismatch is the important thing. So now we have the recovery-oriented approach. We have the stages, and now we have motivational interviewing. And motivational interviewing is a very powerful approach that it takes a very recovery-oriented care approach, and helps move people through the different stages in a very caring, collaborative way. So it really helps people who are in the early stages, people who aren't sure they feel they don't want to quit, people who feel like, well, I kind of want to quit, but I'm worried that if I quit, I'm going to have all these side effects or withdrawal symptoms, through helping people in preparation and developing a plan. And the planning, well, we'll see this in a minute because they have these motivational interviewing processes. So a motivational interview has been shown to be this is why we use motivational interviewing. It's not just a flavor du jour. It's really been shown, and there's a tremendous amount of research on this, to be effective engaging individuals in treatment and developing a collaborative relationship and helping individuals resolve ambivalence and making decisions about change behaviors. So those are like the stages, right? Engaging, developing collaboration, helping people think about why they might want to change more than they don't want to change, and then making the decision about changing. Motivational interviewing, like recovery-oriented care, is strength-based, non-judgmental. These are not always easy to do, by the way. They sound great, but unconditional positive regard, and it works very well with adolescents, because adolescents hate authority usually, and this is not an authoritative process. So it's got the spirit, which is collaboration, acceptance, which includes accurate empathy, affirmations, autonomy, absolute worth, compassion, and evocation. We don't have time to really go through motivational interviewing because it takes a while to learn, and you have to practice it a lot. They also have 4 processes that look a little bit like the stages, but they're really based on what we would do in terms of using motivational interviewing to engage people. What we would do to focus people, like helping people decide what is it we're going to work on. Evoking, which is really developing commitment to making the change about what they're going to work on, and then developing a plan. So those are the processes, and the collaboration is critical in how we do motivational interviewing. And so how we view an individual is key to the engagement process. And it really is an openness to a way of thinking work that's collaborative rather than prescriptive. So we really have to join with the person in a partnership, which means giving up some of our expert role, giving up some of our authoritarianism. I guess that's a bad word, but that we know what's best for the person, and we have to work in a collaborative process. We have to honor their autonomy. They get to choose in the long run what to do, not us, and their self-direction. And it's more about evoking than installing, right? It's like there's certain things we can do in our communication with people, certain ways that we ask questions that bring out what they're feeling about the behavior, things about what they like and things what they worry about in engaging in the behavior. So it's accepting that people have lots of ideas and thoughts and feelings that we could bring out versus installing what we think people should be doing. And we have to be willing to suspend an authoritarian role. And that really, I don't know, we'll go into more slides on this. So these are things, these are roadblocks. People have seen these probably. And these are things that if you're going to do motivational interviewing, if you're going to do recovery-oriented care, try not to do these, because these are called roadblocks because they stop the conversation. So if you confront the individual around their behavior, and this is the kind of the older way of working with drugs and alcohol, people use drugs and alcohol, we confront them. Well, what they found is that has no outcome, okay? So when you confront somebody about a behavior, they tend to get defensive and defend why they should use it or why they're using it. So it instead of eliciting more talk about change, it elicits a lot of talk about not changing. Ordering, directing, or commanding, telling people what to do. No, I hate that, right? No one likes to be told what to do. You like to develop a conversation about what they think might work. Warning or threatening. This is, I worked in a clubhouse for a long time. We used to do this. If you do this, if you go off your medication, you're gonna end up back in the hospital. That's probably true, but that's a threatening, warning thing. It doesn't really help people. For drugs and alcohol, the fried egg and the frying pan didn't really help people. It didn't change behavior. Now, I'm sorry about this. This is lecturing or preaching, which I'm engaged in right now. I should try to avoid it. And judging and criticizing people. So these are things that get in the way of having a type of conversation that could help people move forward in the change process. So some of the things around motivational interviewing, we listen rather than do most of the talking. I feel badly because I'm doing most of the talking, but we're going to listen in a little while. But you know, and by listening, that seems like a simple thing, right? But listening is a skill. And I always thought that people who were going to do motivational interviewing should also do mindfulness practice, because mindfulness practice teaches you how to attend to what's in front of you, to the here and now. And listening is a process of attending and being where hearing what that person's saying and being with that person. It's not always easy. You know, we think our brains move in a lot of different directions. And sometimes somebody's talking and you're thinking about something else. So we really need to pay attention, listen rather than do most of the talking, establish rapport and understand what the help individual is seeking. So what is it that they want? Okay, and the next one is very important. Strive to understand their perspective without bringing in your own agenda. And this is accurate empathy. So when you're here listening to somebody, you're going to enter into their world and see their world through their eyes. So you can't be trying to get them to do something. You have to drop that. You have to drop any kind of judgment, any kind of criticism. You have to drop all that and enter where the person's at. And so you could understand what their life's like. So when we're talking about Femi, what is it about K2 that's important to her? Okay, and not be judgmental and not trying to get her to stop K2, but listening to what K2 means in her life and why it might be hard for her to stop. And then we talked about accurate empathy. We avoid the writing reflex. People know this, and it's where somebody says, "Oh, I have this problem." Okay, I'll use my own example. My wife would say, I'd come home and my wife say, "Oh, I had a terrible day. These things happen." And oh God, and then I would say, "Well, you need to do this." And then she said, "Well, that's not going to work." Right. And it's when you're working with somebody and they keep telling you why your ideas and suggestions don't work. And they don't work because my wife didn't really want me to give her a lot of suggestions. She wanted me to, and usually I do, when we do in person, I usually say, she wanted me to, and everybody says, listen. So we have to avoid jumping in too quickly and offering suggestions. It doesn't mean we never offer suggestions, and we're going to talk about how to do that. But in the beginning, you avoid that. And role of resistance. So if a person says, "I'm not ready to quit, I really like K2," you have to figure out how to reflect that or to shift focus and to keep so that the person sees that you're still with them and that you're not taking a position that they need to change a behavior they're not ready for. Okay, so people know these is the core skills: open-ended questions, affirmations, reflections, or summaries. And you could use these in all kinds of ways when you're doing motivational interviewing. And you could do open-ended questions to really evoke what people might be worried about. If you said, if somebody was smoking, you could say, well, what do you like about smoking? And they tell you, and they say, well, what are the downsides? And when they tell you the downsides, that's considered change talk. And you're using open-ended questions in a very genuine, serious way because you're interested. Okay, we really can't, this is not a training in motivational interviewing. It's just going through how to apply this. And then when you ask a question, you want to reflect. You don't want to go on to another question, or you don't want to tell them what they should do. You want to reflect back what you heard and what you think they meant by what they said. So if everyone keeps telling me to quit drinking, that I would feel better and healthier, they don't understand how much I need to relax. There's repeating, which is just giving the words back. You could see that. There's rephrasing, which is basically giving the words back, but changing the words a little bit. And when you do repeating and rephrasing, those are considered simple reflections. But those in the beginning could be very, very powerful, because when you do that, there's no criticism in it. There's no judgment. And people realize that you listened to them and you heard what they said. And that goes a long way to building the relationship. But then the more complex reflections, which would, they look at a little bit of the meaning. This is what they meant by what they said, but they also have this other thing that might be in there that we think, and you give back kind of an added meaning, but it's not an interpretation. And then they respond to that, and you can continue the conversation. So paraphrasing underlying emotions are methods for keeping the conversation going. If you did just repeating and rephrasing, that's a dead end, right? That's circular, and it ends up being annoying to people. So you could start with simple, but you need to move to more complex. And we talked about when can you give advice and information, okay? Well, you give it in two ways. If somebody asks you for advice, then you can give it. Well, this is what I think. But you would always say, but it's really up to you what you decide to do, okay? Or if they didn't and you want to give advice or you want to give information, you ask permission. I have an idea. Would you like to hear it? You might want to try this, but it's completely up to you. So really allowing that autonomy to continue in the relationship, that you're not in charge, that they're in the driver's seat. So that's giving, that's a core piece of motivational interviewing. And now we're getting into the last slides around harm reduction. And harm reduction and motivational interviewing go hand in hand. And in harm reduction, and we mentioned this, you got to accept that the individual does not initially want to stop using drugs or alcohol. You have to accept that, with your whole heart, kind of. You're not like, you're not trying to manipulate them. You're not trying to get them to change. You accept that's where they're at. You respect their autonomy. You place individuals' perspective and wishes above our sense of what is best. Okay, so that's a really key way of engaging with people. Treatment begins where a person is at in terms of their needs and goals. We talked about around the stages. This is an interesting thing. You had to set aside our own fears, values, and choices in order to assist the consumer in making his or her own choice. So, we could talk about this when we get to FEMI, because the clinic is afraid of what she might end up doing to herself because of her substance. And we might need to put all our fears and values aside and figuring out what Femi really is interested in. What is her choice? Okay. And that's an interesting thing to talk about. Person communicates what's important for them in terms of treatment focus. We communicate. This is how it goes into these all fit together, right? Recovery oriented care and motivational interviewing. We use shared decision making. Here are some ideas I have. You might be interested in this information about this, and then, but you get to decide based on this. What do you know? Here's what I know. What works for you? What are your preferences? And what is your choice? Okay. And the last thing is, we don't see the person as in denial. That is not a good word to use. They're not in denial. They can't figure out how to live their life without this substance. It's not in denial. The substance is so important to them that if they stop, they would feel like they would be at loss. They wouldn't know what to do. So we don't want to use the word denial. Denial is one of those roadblocks. Okay. And we want to, now we'd be interested to help achieve a gradual reduction in harmful consequences. So it's not getting people to stop the substance if they're not ready, but what could we do to stop the harmful, or to help them figure out what are the things that aren't so good about this and how we could do something different. It's targeting associated problems rather than substance use may be the best current thing we could offer. And so we could talk about switching to less strong cannabis, or maybe switching from K2 to cannabis, and use strategies to improve medication adherence, provide practical needs. You could shift the focus away from the substance and around what things would make your life better. What do you need? Housing, going back to work, whatever it is. And those are not contingent upon substance reduction in substance. So it's not like, and we used to do this. We'll find you a job, but you have to stop using for 6 months. Okay. But now they found if people are using and you get them a job, then they tend to use less. Okay. Because they want to keep their job, or they want to get through the job interview. So harm reduction is a key piece, a component of integrated treatment. And the summary, be consistent and persistent in your effort to actively involve. This is the assertive engagement. Be non-confrontational, confrontational, use accurate empathy and compassion, which is really caring for the person. It's not sympathy, it's not pity. Always provide practical assistance, because sometimes people come in and they don't want to work on even their mental health. They want housing, they live in a shelter, or they want, they don't have any money and they need benefits. So that's really important. Reach out to individuals and provide services in a natural living environment if that's possible for you. If you have like an outreach team, or you have case managers in your clinic, or you have other ways of reaching people, or if they're really struggling coming to the office, which is really hard for people, you might think about referring them to an ACT team who can provide the services and living environment. And the last thing, and I got this from a consumer who was in a meeting. It was like a case conference. He was a consumer that worked in the program, and he said, change takes time. It really happens. It really happens overnight. So his little thing was actually over time, not overnight. So we have to remember that, and that's just the patience. That's being patient with people. So are we, okay, so we're gonna move. I don't know if people had, I don't know. I talked a little bit, I'm sorry. I don't know if people, well, let's see how this goes. We'll do it this way. And then you're gonna have lots of questions and answers. And then there's a survey to think about what you thought about today. So this is the FEMI, case, okay? And, we have to figure out another term beside, I haven't talked to anyone from the organizing group, but we should find another word beside case conference. People always, consumers always say, we're not cases, right? We're people, right? So I don't know, maybe we could use a care conference or, but anyways, let's just call this a care conference. And this is the information on FEMI. And so the question is, did we have the other one that said, then we have one that said, what additional questions did you have about FEMI? Oh, okay. All right, we don't have that. Okay. Because let's just think about that. Do you have think about here, I'll remember it from this. I have a little okay. So do you have any additional? Oh, okay, you did. Oh, Nancy, you're so great. Okay, so are there any questions that you have about FEMI that's not in the care conference kind of script? Is there any questions you have about FEMI that you would like to ask?
And this is Yvette. I'm just going to remind folks that if you have any questions or comments or want to respond to Rusty's questions, please feel free to chat them in the chat box.
Oh, yeah, good. Thank you. And then Nancy is going to, we can answer that through the chat box, but Nancy's gonna, when we do the brainstorm, is gonna write what we put in the chat box on this document, so we have a way to look at it. So are there questions? Okay, let's see now, the chat. Okay, these are great. What role does abstinence have? Okay, now, is it what role? And let's see who wrote that. Okay, so that's Kristen. And Kristen, did you mean what role does abstinence have in the slides in this core components integrated treatment, or what role does abstinence have in FEMI's life? You could use your audio if you want to, if you just want to unmute yourself. Okay, so we'll go on, and Kirsten, you could put that in the chat box, and then Kirsten also said, other social supports, details of prior work history. Yes, there's two things about that. One is social supports is critical in the recovery process. So that's a very good thing. And we know she has one social support, which is her sister, but I don't know about any others. And details about prior work history, right? She wants to go to work. She has a very good goal, and it's ambitious, but it's a very good goal, is to get certified as a nurse assistant. But is there any other work history that we can pull on in terms of where she was successful, because we don't want to just find stuff where she failed. We want to find stuff where, and what worked when she was working, what helped. What does she think has helped her? That's a question, right? These are great. These are great. Let's see. She's got a goal of returning to work as a CNA. So has she been trained? Is she currently certified? Where did she work last and what happened? So those are a lot of questions, and those are really, related to goal. So it's really questions related to things that are important to her, which is really good. Okay, it's not just looking at things that were were hard. It's not looking at negative things. It's not looking at diagnosis. It's looking at helping her in moving forward in something that is her preference and something that she's interested in. What sort of clean time has Femi had, if any, and what was life like when she was clean? So that's an interesting thing, because she did stop using marijuana and alcohol. So these are like the brainstorms, really, because we could ask her how, what changed when you stopped. We can ask her, what got you to stop smoking marijuana? What was it about marijuana that you decided this is not for you? You wanted to stop. And then what's changed? What's changed for the good for you? What has been the benefit for you? And, because then you could use that if we ever open a discussion around K2, and, saying, if she said, I don't feel like I could stop K2, and you said, well, you seem to have stopped cannabis. What worked there, right? And so you could apply that to this other thing. You could apply that to these other things that maybe we could think about ways to help her, maybe open up some ambivalence about K2 and crack cocaine in general as a concept. Okay, Kristen, thank you for writing that. I'm trying to find.
That was the question about the role for abstinence.
Okay. All right. So, in other words, in the presentation, what's the role of abstinence in presentation? And, in harm reduction, the full harm reduction, true harm reduction, right, would be people stop, right? When people stop, the harm related to using, gets resolved, right? So abstinence is not part of harm reduction, but that's when a person's ready to stop, okay? But a lot of people aren't ready to stop, and so we want to apply harm reduction approach to people who say, I'm not ready, or I can reduce a little bit, but I'm not ready to quit altogether, right? So I don't know. You could tell me if that makes sense, Kirsten. Let's see. What did Femi feel was helpful in prior treatment? Letting her talk about what she would like to talk about in the first and second session. What did she enjoy about being a CNA? Okay, so these are like, I have to say, we're kind of moving into brainstorm because it's really like things we might want to do with Femi that would resolve some. So could we I'm going to take the chat box down for now. Let me just go. Okay. So, and Nancy put in the questions, but in the chat, in the brainstorm, we want to ask first, what would be the focus that you would want to work with Femi around? Where would you start with Femi? Okay. All right. So Ryan said, build connection. And so really engaging, you're right, engaging and developing that work relationship, right? A collaborative work relationship. Is that okay to say, Ryan? Did I put too many words out there? Is that what you meant? Yes, find ways to engage, like playing cards. Ryan, I love that you were specific, because playing cards takes the pressure off of trying to get Femi to change, right? You're just trying to develop a relationship, and playing cards is non-threatening, non-critical, non-judgmental, but it's a good way to engage in an activity with Femi. And I think we want to be specific when we say these things, okay? So, and I like that you got specific. It's like build connection, but the question is, that's where you would start. And then in the brainstorm might be, what would you do to build connection? And you said playing cards, okay? Now that, a lot of that depends on Femi, if she hates cards, if she hates cards, it's not a good way to start. So, part of it is, what do you like to do? What do you enjoy to do? And it's really starting in a positive way with Femi. And it's like appreciating who Femi is. Play music she enjoys, find things that she likes, and engage in a conversation around those. Okay, that's great. Build rapport. You guys are terrific. This is great. Building rapport by asking about her interests. Ask more about what she wants for her future, or just listen to her current struggles and validate. And that's a very good, that's Charmaine, it's a really good motivational interviewing approach, right? And in the asking about her interest and asking about what she wants for her future, those are open-ended questions. And when you ask that, when she responds, you try to reflect back what you think she meant, okay? You don't just go to another question. So you want to explore that. Or you could say, I'm interested in, I don't know, what would Femi be interested in? What would Femi be interested in? There's more that are really good up here too. Okay, we'll come back to that, but this is like this is a fictional person, so we could say anything we want about what Femi's interested in, but you could say, well, I like music, and then you could say, well, tell me more about that. What music do you really like? And that's engaging in a conversation and developing a relationship and treating her as another human being, not as a treatment object, or what I mean? I'm not saying you guys do that, but I'm just saying we want to treat people like human beings. And that's an important piece. And that's, you start with what they're interested in, And we had another one. It said, identify, this is from Sonia, identify her strength, her role in her family with her sister. Okay, so are those, Sonia, are those two different things, or is that one of her strengths is that she has a fairly good relationship with her sister? And, we talked about supports and asking more about supports, what support she has in her life. And this is all connected to the concept of resiliency, because resiliency has to do with helping people identify their strengths and affirming their strengths, and also identifying what supports she has in the community. So the sister could play a very key role in the work we do with Femi. And I don't know about the father, but we could talk about that. So how did she feel about quitting alcohol and how quitting those drugs have changed? Okay, this is from Deborah. It's how did she feel? So this is a question that you would ask. This is part of the brainstorm. How did she feel? Femi, how did you feel about quitting alcohol and marijuana? And how have your feelings about quitting those drugs changed? Deborah, can I, sometimes I give a little feedback. Do you mind if I give feedback on that a little bit? Are you all right with that? You can give a thumbs up. Oh, please do. Okay. So the first part is great. Okay. How do you feel about quitting alcohol and marijuana? But then if you ask her about her feelings about quitting those drugs have changed, do you mean how have your feelings about these drugs changed? I mean, you don't want her to start saying, well, I'm not sure I should quit. You don't want to open up, what's called sustained talk. So I was thinking, did she want to quit initially and then her feelings change? You see, Deborah, I'm not sure we would want to have that kind of question, because she might, we might wake up a lot of ambivalence. So it might be better if we said, what helped you change? Why did you stop smoking? And what helped you change? Okay. And that's more of an affirmation. And we could even say, we could even do strength-based stuff. And I know how difficult things have been for you recently, and it shows you have a lot of strength to be able to quit smoking marijuana and to stop drinking. Okay. And you can then say, how did you do it? What helped? Right. And then you hope that those things could slide over to the K2 and the cocaine. Let's see. Personal strength. This is from Charmaine. Personal strength. She believes in taking, yes, she believes in taking psychiatric medication and has been taking consistently. Applying, she has some trust in relationship with residential staff who help her manage that. So there's two things. It's like, we would want to affirm how important she feels it is to know how important taking her psychiatric medication is. And also you raise a good thing, which is the residential staff is part of her supports. She trusts them and they're a part of her support system. And this is where one of the things around collaboration is not only we want to collaborate with the person we work with, we want to collaborate between programs that somebody is attending. So there should be a collaboration between the clinic and the residential program. And it's very important. Residential program, the person is with them a lot. Okay. And they live there. Femi lives in the residential program and she's with the residential counselors a lot, and we need to touch base with them, and they might help motivate Femi to attend her clinical appointments, okay? And to help her make sure she gets her prescriptions filled. And, to make affirmations and like, when you really, you're really taking your medication, and when you really want to do something, Femi, you really can do it. Okay, so we could do affirmations, strength-based statements. Okay, so we have a bunch of brainstorms, but we need more. What else would you recommend we do with Femi that would help Femi? And you could, Nancy is a fabulous, I don't know how she does it, but she's very fast. And so if you said it, if you don't want to type it, you could just unmute yourself and just say, this is what I think. Okay, Olivia said, inquire more about her desire to return to work. If she's serious about the desire, she may be able to indicate what steps she has to take, making this a goal if she wants it to be a goal. Excellent, perfect. And, this is what we were saying about substance use. It used to be, you had to stop your substances before we would do this thing. But we found that it's making the changes that help people stop their substance use. For instance, if a person wanted housing, we'll help you find, this is a Housing First program. We'll find you housing. Doesn't mean you have to stop using. It's not contingent you stop using. We want to find you housing because you don't have housing, right? And so we're going to do that. And when people get housing, it's more likely that it'll impact on their substance use. That doesn't happen on everyone, but they'll stop using as much. It's the same thing with work. Instead of saying, you need to stop your medication, or I'm not your medication, your substance use before we'll help you find a job. If we start helping them figure out the steps to take, and this is what you were saying, what steps does she need to take? And, if she wants to be a CNA, and she is not certified, what's it going to take to get her certified? So she's going to find what she needs to do. And along the way, you could say, listen, how does your K2 impact on your getting this, right? Or she might realize it. She might, when people go back to work, they have to do urine screens for a lot of places. They have to be, they can't be high and stoned when they go to work. They can't be drunk when they go to work. And so work might be so important that they cut back. And motivational interviewing is called developing discrepancy. There's a discrepancy between something that's really important for them and their current behavior. And when they really want that goal, they are willing to cut back on their substances, usually. And it doesn't mean they stop altogether, but when people cut back, harm reduction also says when people make a step at reduction, you don't say, well, you need to be abstinent. You say, that is great. How did you do it? That is incredible. And so people build off of, it's like it builds their self-efficacy. It builds their sense that they can do it, right? And they might keep doing it, and they might keep making more changes. And work becomes somewhat of a motivator. Yes, Olivia, perfect. Yes. So these are great. Any other, do we have other, Deborah, inquire about Femi's perspective of her mental health symptoms. What does she recognize as factors that exacerbate their symptoms? So now that's great, Debbie. And it's like asking an open-ended question again, right? I know sometimes you have things happen in terms of mental health, and you end up in the hospital because your symptoms seem to have gotten worse. How do you view that? How do you view your mental health problems and the symptoms getting worse? What happens? And ask it in a sincere way that you're interested. And I know you would be interested, but you're interested. You're genuinely interested about Femi and her life and what happens with her and her perspective. And that is great. And that's going to give a sense why, why is she motivated to keep taking her medication? What's that about? And by the way, and I know people know this, but in the DSM-5, there's a cultural formulation interview. And when you look at it, it asks a certain number of questions about people's perspective on, for instance, their mental health problems and how they view it, and how does their family view it. And it's a fabulous way, because it tells you what you're trying to achieve, and then it gives you the words you could say. You don't have to say them word for word, but it gives you the words to say. So I recommend the cultural formulation to help with asking cultural, specific questions and understand, because people's understanding of symptoms and we have Femi's Jamaican. So how do Jamaicans might have a different perspective than we do on the types of symptoms. So the cultural formulation, but thank you, Deborah. That was very helpful. Other people, brainstorms. We're supposed to get 20 of these, because then we're gonna have hopefully, I don't even know what time it is. I don't know how much time we have left. Let me look, because we're going to.
We have about 15 minutes left. We're going to go to 11:30. Okay,
excellent. So when we do all the brainstorm, then we're gonna. I don't know how. I'm not exactly sure how we're going to do this, but usually when we do this format, you have one person doing the care presentation, and then everybody engaged in the brainstorm, and then one person, the person that presented it, picks 3 things that they think will really help Femi, and they try to do it. They make a plan and they do it, and then usually, this is monthly, and you come back and everyone will say, "Hey, what happened with Femi?" So, so maybe we get a volunteer who will pick 3 things. I don't know. We'll have to figure out how to do it. But we need some more. Well, need is the wrong word. It would be great if we had some additional kind
Hello?
of. Yes.
Yeah, I'm sorry, I'm in traffic, so I don't want to raise my hand or chat. But I thought that it would be good to maybe do collaborative documentation. I think is very helpful in engaging clients and helping them. It gets them to set the goals. It gets them to, feel more accountable. Also, linkage to a peer, I think, is very helpful outside the office, outside the bureaucracy, going to self-help. Having someone to talk to, I think, is very important. And wellness and recovery plans is a good collaborative documentation tool that clients use, and also adds as a support when they're not in session.
Yeah. Well, John, we want to commend you on your dedication to being part of this discussion today. and we hope you do get out of traffic. Where are you coming from?
Oh, I have to go sign a check for a client.
Oh, well, and you had excellent ideas and collaborative documentation, and it didn't used to be this way. We used to do a treatment plan and then just have the person sign it. And, we came up with the goals, we would talk to them, but we came up with the goals. We came up with what should happen. And a collaborative documentation is very important because you're asking the person, what goals they have, how do they want to go about achieving the goals? What are their preferences? And you can always add, it's collaborative because you could always ask, and you can always add, well, I have some ideas what you might be helpful. Could I give them to you? Could we? And so it's not like you're doing an authoritative approach. You're doing a collaborative approach, and you're saying, look, I have some ideas that you might enjoy, or here's some things that other people have the same problems that you're going through. Here's what they did that they found helpful. Would you be interested in that? So a collaborative documentation is very helpful. And when they do, and you put this word accountable, because when it is their plan, they're more likely to follow through. When it's our plan, they might sign it. They might kind of agree to it, but they're going to not really follow through. And that's when we get frustrated and people say, I don't understand it. They signed the document, they agreed to these goals, but they're not following through. And the reason is because they're not really committed to the goals that are in the plan. So, so that's great. And you put giving advice with the permission, terrific. And linkage, we didn't mention that, linkage to peer outside of the office self-help groups, which would, we can suggest that, and that would expand FEMI's support system. And doing a wellness, doing a RAP plan, add support when not in session. These are great ideas, John. Thank you. Can you hang on the phone?
Sure.
Okay, great. We're glad to have you.
Rusty, I just wanted to mention that they will need the last 5 minutes for the wrap up in the survey. So I didn't know if it's 11:20 now, if you wanted to spend the next 5 minutes picking, or if you wanted to do some additional brainstorming.
Okay. How she feels about being on. She might be okay. So one more. This came from Kristen, which is, is there a way that we could talk to Femi? Can we elicit Femi's dislike? We don't even know how she feels about the hospital, but is there some way we could talk about what it's like to go back into the hospital for her? Because lots of people will say that, what's your goal? I want to stay out of the hospital. And that is their goal. So, okay, so do we have a volunteer who will pick one or two that you really think would win? Not win, but would work. Do we have a volunteer? You can't go. Oh, and I just want to put Helen Haldane. I like the collaborative goals to be measurable. So when we review the goals, they can see the progress. Yes. I've done lots of training with care managers around documenting, and we use SMART, right? That you have the goal is broad, but the steps you're gonna take to achieve the goal need to be specific, measurable, so you know whether what you're doing is working, and achievable for that person. Yes, I can do that. Doesn't mean 100% they can do it, but yeah, they feel confident they can do it and relevant to them, okay? That this really is important in my life. And then time frame. So we use the SMART acronym. But anyone, oh, the pros and cons of, oh man, I love that. Pros and cons of K2, they're still coming in. I guess maybe this is hard to do, to select, to have someone, anyone would just jump out and say, this is the 3 things I would try to do. Or maybe 2 things. All right, it doesn't look like are we sending this document, the brainstorm, are we going to send that to everybody so they can look at it? Is that possible?
Yeah, I'm sure we could
Okay.
make arrangements to send that out.
Okay.
Yep.
All right. Well, I guess we're like, need to stop. You guys were great. This is a great brainstorm, and you have lots of skills and expertise in this, and so I really appreciated people that joined in. And I just want to say something quickly about the co-occurring mental health and substance use disorders. And a lot of, if you're in a mental health, a lot of people get in the clinic, a lot of people get worried that they don't really know how to treat and they don't understand drugs and alcohol. And I just want to say that the skills that you have as a clinician slide over very easily to working with somebody with drugs and alcohol. The only thing you might need to add, and I think we did this last month, was some basic information about drugs and alcohol 101. Just, how they work, the withdrawal, and all that kind of stuff. But you've got all the skills. You guys know motivational interviewing, recovery-oriented care, harm reduction, all this stuff. And it's the same thing for people in addiction treatment. So you're all well equipped to really provide integrated treatment when people come in who have co-occurring disorders. So.
Thank you, and I'll pick it up from here. So I just want to thank our presenters, thank today for the great conversation and information that has been presented. If you have any follow-up questions about today's presentation or like to learn more about some additional resources that were available, the presenters can be contacted at the following. We just go back to your email addresses for the group. So that's their contact information. We've also provided a number of links in the chat box section. So there's the link for the case submission, the link to the training page where you can find the past offering, and lastly, the link to the feedback survey. We hope that you take a moment to fill that out. We'd really like to hear your feedback about today's presentation. We do use those to kind of improve upon future offerings, so we will appreciate that. Again, we just want to say thank you to everyone. Thank you for joining us. We appreciate the time that you took to be with us this morning. And again, we will be sending out the slides and recording. And again, if you have any questions, you can reach out to MCTAC directly or the presenters. And with that, we'll give you just a few minutes to complete the survey, and we will see you next time. So thank you.
Yes, thank you.